And hello, everyone. Thank you so much for joining us. I'm Stephanie Jackson, and I'm the medical simulation sales rep for 3B Scientific for the southeast part of the United States. I see people are kind of still logging in right now. So while everyone is getting situated, I wanted to quickly just introduce myself and 3B Scientific, and then we'll go into the really fun stuff with Dr. Lungani. I started with 3B Scientific back in 2006, and I was the biomedical and simulation product manager. I just want to emphasize that I truly love simulation and working with medical educators to find the right product for their needs, and of course, at the right budget point. I like to mention that I've been in the medical education and simulation industry since 2006, because 3B Scientific represents thousands of products in the field of medical education and simulation, much more than what is often represented in our catalogs and online. So I like to remind my clients to just reach out to me and my colleagues if there's a training need that you have and you're wanting to fulfill, but you're not entirely sure where to find it. Chances are we can point you in the right direction and save you loads of time searching. So real quick, here's our agenda for the day. We'll talk a bit about 3B Scientific, our speaker, Dr. Lungani, and then focus on urinary catheterization, the pitfalls, the common mistakes, how to avoid them, when to call for help, and more. And then finally, we'll close with a brief Q&A session. So just real quick, at any time, if you have a question when we're going through, just type it into the chat box and we'll make sure to try to bring those up at the very end. So who we are, 3B Scientific, our mission is to advance medical and healthcare delivery through the quality, breadth, and global reach of relevant educational and simulation products. Who we are. We do this in many ways. 3B Scientific was founded in 1948, and we are one of the world's longest lasting and leading manufacturers of medical and science education solutions. In addition to our own simulators, task trainers, and anatomical models, we have brought on the popular brands of Cardionics and iSimulate to join the 3B Scientific family. In 2019, Cardionics joined us, and they continue to set the pace for the highest quality auscultation training in both simulation labs and SP programs. And even more recently, at the beginning of 2020, iSimulate joined us, and it's been exciting to take healthcare simulation to the next level to provide innovative simulations of patient and vital sign monitors and a wide range of handheld health monitoring tools. At 3B Scientific, we are always growing our product line, so once again, reach out to us and have a chat about your needs. I often surprise my clients in the fact that we can offer so much more to them than they originally thought. So that's who I am and who 3B Scientific is, and now I'd like to introduce our special guest speaker, Dr. Rajesh Lungani. Dr. Lungani is a board-certified urologist who specializes in adult urology and urologic oncology. He is fellowship trained in minimally invasive and robotic surgery. He's a member of the medical staff at Piedmont Hospital here in Atlanta, Georgia, where he serves as the director of minimally invasive and robotic surgery. He has received numerous professional honors in recognition for his outstanding work, and he has also been featured on CNN's Medical News. Dr. Lungani has numerous peer-reviewed publications on urological advances in robotics and has lectured and operated internationally, including Egypt, Malaysia, and the Czech Republic. And so we're excited he's joining us today in our offices here in Atlanta. Dr. Lungani will be using the Catheterization Simulator Set Pro version, which you see here on the picture. It has easy to change genital inserts, and it's held into place with magnets. Both the inserts are made from soft, flexible material, and the foreskin and labia are movable and the penis can be stretched. The student can easily practice all necessary gestures for catheterization, and the Pro version includes the top part of the thighs, making it more realistic and challenging for students. Our state-of-the-art material gives a realistic feeling when inserting and removing the catheter into the bladder, with both a realistic resistance and realistic insertion depths. So you'll also see in the background when we start our video and really dive into this training session that we have a full body mannequin set up as well. This is our newly released Nikki, the nursing mannequin with auscultation. You may recognize its body from our best-selling nursing mannequin, but due to overwhelming requests, we have added the cardionics auscultation technology to our nursing mannequin. So again, I'm pointing this out because the same features in the catheterization simulator that we're using today are found in our full body mannequin as well. And honestly, if you know anything about 3B Scientific, you know we like to offer as many variations of products as possible to make sure that we're aligning with your training goals. In addition to the task trainer, Dr. Langani will be referencing some of our anatomical models, which are featured here. I know many of my Sim Center clients often purchase our anatomical models as well, just to help give visualization of the internal anatomy and a refresher during their educational and training sessions. So one side note I want to mention, you'll see from these images right here and perhaps on the screen shortly when we start our presentation, that our anatomical models now include a QR code with them. And I'll show you just a tiny bit about that. I'm going to hit play there. So 3B Scientific, we launched the innovative concept of combining extensive virtual content with all of our original anatomical models via the app 3B Smart Anatomy. And with this exclusive upgrade, you have immediate access to the courses in the app, giving anyone on your team and even your patients for patient education access to incredible educational material of the human body. So without further ado, I'm going to hand things over to Dr. Langani. Great.
All right, well, thanks, Stephanie. That was a great intro. I want to thank 3B for allowing me to participate in the meeting and this educational experience, really focusing today on urinary catheterization. There are a lot of things that go into urinary catheterization. It's not just simply placing a tube in a hole, okay? A lot of pitfalls, a lot of potential complications. So if you know how to do it right, you use the correct technique, and you understand what catheter needs to be used when, you likely will have success. So, you know, the first thing to understand about urinary catheterization is why do we need to do it, okay? The most common indication that we see in the hospital setting is urinary retention. We see this in the hospital as well as the outpatient setting as well. So where I left off was, again, indications for urinary catheterization. Again, we talked about retention as a result of an enlarged prostate causing outlet obstruction. We talked about possible neurogenic bladder, where the muscle wall of the bladder does not contract appropriately, secondary to maybe spinal cord injury. You can even have blood in the urine that's so severe that those clots can accumulate within the bladder and requires absolute acute catheterization to help drain the bladder. If urinary retention is prolonged or untreated, it can result in potential changes in kidney function, because you have to understand that pressure has to go somewhere. So it will eventually go up to the upper urinary tract. It can cause a condition called hydronephrosis, which long-term can lead to acute renal failure. So addressing urinary retention is extremely important. Something to understand is that, you know, there are many different types of catheters, and each catheter is used for different clinical scenarios. So I'll kind of address and speak to some of those catheters. For demonstration purposes today, we'll be using a silicone straight catheter, okay? But typically in the hospital setting, there are, like I said, different types of catheters. So the one I'm going to show you here is what's called a Coudet tip catheter, okay? The Coudet tip catheter is a straight catheter. It has a balloon on the end, but it's got a curved ball at the tip. And what this is typically used for is catheterization in a complex male. And what I mean by a complex male is maybe somebody who has an enlarged prostate. And the reason we do that is because what you may think is when you put a catheter into a male bladder is that it's a straight shot, but actually it's almost like a roller coaster ride. So if you look at the anatomy model here, what you can see here is here's the urethral meatus, or the opening to the penis, and the urethra travels thus far. And really where it becomes more of a roller coaster, like I alluded to, is right by what we call the membranous urethra, right before the urethra connects to the prostate, okay? And this is a problem where a lot of trauma can occur if the catheter is forced. So that Coudet tip catheter has that curve that allows it to get past that bump and safely go into the bladder. So we use this quite often in men who have enlarged prostates to try to avoid catheterization, or trauma rather. This is another type of catheter. Now this is what we call a hematuria catheter, okay? This is for a patient who may present to us with severe blood in the urine, such that clots have accumulated within the bladder. And the nice thing, or the different thing about this type of catheter is it actually has metal coils or rings within it. It's a large bore catheter with about 3 openings on the tip. And the reason this is useful is because when you place the catheter in the bladder, when you try to what we call irrigate the bladder, meaning push fluid in and pull it back out to try to evacuate those clots. A normal catheter without these rings, when you pull back on that irrigation syringe, it'll collapse because it's suction. And if the catheters collapse, you can't suck anything out of it. But with these metal rings, the catheter does not collapse. Okay, so you're able to evacuate large amounts of blood clot to allow the bladder to drain. The final catheter I'll talk about is what we call a council tip catheter. And this is a red colored catheter that typically, if you see on a patient, it means a urologist has been there. And the reason it's special is because it has a little tip or a hole at the end. And the reason it has that tip or hole is mainly because if a urologist gets involved with catheterization of a patient, a lot of times they have to do it with cystoscopic guidance. You drive a camera through the urethra into the bladder, and then through that camera, we actually float a wire, okay? We take the camera out, and over that wire, we actually can float this catheter directly into the bladder, okay? So in patients where there's significant amount of trauma or real difficulty getting into the bladder, we actually just pass the catheter over the wire. So that's kind of a quick crash course in some of the catheters that we use. What's really important whenever you catheterize a patient is appropriate lubrication. So there's a saying in urology, you can never have enough lubrication, and that's true. So this is what we call a Urojet. It actually is lidocaine jelly with lubrication, and makes a big difference in terms of the ability to successfully catheterize somebody. So like I described here, these are the anatomic models, both male and female. In men, the main pitfall is trauma associated with what we call creation of a false passage. And that false passage occurs right at that membranous urethra where the anterior urethra meets up with the prostate, okay? So if the catheter is jammed or pushed through too forcefully, it'll actually create a false passage. And this tissue here is extremely vascular. So you'll see immediate return of blood in the urine, okay? That's usually an indication to stop what you're doing and call for help. And that usually means call a urologist. In a female, typically some of the things or pitfalls you may run into are things like urethral narrowing. Sometimes in older patients, you'll see urethral prolapse. Those aspects aren't difficult to catheterize necessarily, but something to be aware of where you may want to use a stiffer catheter like a silicone catheter to try to get into the bladder. So what I'm going to demonstrate is how this anatomic model really helps with education regarding how to catheterize someone, and again, safe techniques in order to go ahead and do so. All right. So in this case, what we've done, we've set up the male model, and it is interchangeable with both the female and the male model. Okay. Some of the other aspects that you may run into is, in this case, the meatus is open, but sometimes obstruction can occur at the meatus, or the opening of the penis, which is called meatal stenosis. So that's one aspect that can cause obstruction or difficulty with catheterization. But in the female model, you have the labia, which can spread apart easily, and you can see the urethra is located directly over the vaginal opening. Okay. In the male, this is somewhat realistic, mainly because you can move and grab the penis appropriately. So when you are catheterizing, again, like I said, it's important to use the appropriate amount of lubrication. And I said for demonstration purposes, we'd be using this more stiff silicone catheter. So we'll put some lube on the table here, make a little mess. Urologists are known for making messes, so that's perfectly acceptable in our field. Okay. And then what we have set up here is we've got what appears, what would be, I guess, the bladder here full of fluid. Most urine is not blue. It can be blue in some cases with particular medications, but on average, urine should be yellow. And what I'll do is I'll demonstrate how to catheterize first, but then I'll take this model apart so you can see exactly where that catheter is going and how it's working. So it's very simple. Like we said, appropriate lubrication, like I said. You grab the penis appropriately. You have to use some firmness there, okay? And understand, as much as you're trying to help the patient, in some cases, before you help them, you have to hurt them a little bit. So a little bit of pain and discomfort is to be expected with catheterization, but you want to explain this to the patient before you do that. Appropriate lubrication helps with that. And you kind of gently insert the catheter moving forward, okay? And again, we're known for messes, so I'm going to make sure I don't make too much of a mess here. As the catheter goes in, the nice thing about this model is that it has a constrictor device on the inside. And the constrictor device allows you to understand different levels of resistance, okay? Because one of the things that's really important to understand in medicine and in surgery, and you can see here how well it's draining, okay? Almost extremely realistically to how a normal bladder or catheter would drain. One thing that's extremely important to understand about medicine and surgery is knowing when to force it and when not to force it, okay? So if you're pushing too hard or you're trying to force something, there's a greater likelihood that you're going to cause trauma to that patient. So the constrictor device really allows the individual, the student, whether it's a medical student, a resident, a nursing student, to understand how far or how hard you have to push. And the constrictor device comes in 3 levels: wide open and patent for probably what would be a straightforward patient, somewhat constricted, which may be for someone who has a stricture or maybe an enlarged prostate, and the completely blocked off for someone whose urethra is completely walled off, again, due to things like scar tissue or, again, some other level of obstruction. So understanding exactly how hard or how far you need to push something is really important. And again, at the end of the day, if you're with a patient and you're catheterizing them and there is any uncertainty about where the catheter is located, is there trauma, am I in the bladder, you always call for help, and your local neighborhood urologist will potentially come and help you. Okay. Something that's also extremely important to understand about catheterization, which a lot of people don't recognize, is the lubrication that we use is thick. So when you smear it on top of the front of the catheter and you put that same catheter in, that lubrication sometimes gets caught in the tip of the head of the catheter. So when you put fluid in the bladder, or you put the catheter in the bladder, you may not see immediate return of urine. Doesn't mean you need to panic. It means that urine needs to just kind of push that lube out of the way to pass into the catheter. So what I'm going to do right now is break this model down, and I'll show you how we can kind of interchange this between the male and the female model. It's very easy. You want to clamp off your bladder here, or your supply, okay? And what you can do here is take this off. This is where the magnets attach, okay? And simply what you do here is the constrictor device, okay? And again, as it's lifted up, you can shift this little piece back and forth, and it goes from, again, open to partially open to completely open. That's the completely closed setting, okay? And that wouldn't allow you to potentially pass a catheter in, okay? So that's one aspect of this model that I've really never seen before in other simulation models or other catheterization devices. So again, I'm going to do my best here not to make a mess, but please excuse that.
We have a cleanup squad if, yeah.
Okay,
I'm happy to help.
so here we go. Bladder is full. Patient is in urinary retention with urine. So it's very easy. You can see how I'm just twisting on the vaginal replacement, and then again slides back in. Okay. And this tubing here is set up just like any IV tubing with clamps. Okay. This bladder is empty now, but it's full in there. And we kind of put this aside, like I said. And then in the female, again, catheterization is relatively simple. Again, always lubrication. And again, some challenges we run into with a female is also body weight and body habits, okay? Because the male penis is more of an appendage. It's not always difficult to find, but in, for example, an obese female, what you may run into is difficulty actually separating the legs, spreading the thighs, and finding the urethral meatus. Again, always understand or know your anatomy, that it is located above the vaginal orifice. We've seen patients before have their vagina catheterized, and the nurses will call us and say, I don't have any urine output. And well, that's because the catheter is not in the bladder. So again, here, anatomically and realistically, in terms of quality of the tissue here, just placing the catheter directly in, and again, my collection cup here, you'll see the bladder drain, okay? So for all intents and purposes, again, the anatomic models here for both female and male are very realistic. I think the main advantage that you run into with the male is, again, that constrictor device. It really helps gauge or have an understanding of resistance. And that's one of the things that can get most students or nurses or doctors into trouble when they're trying to do safe catheterization. One of the pitfalls when it comes to female patients that's important to understand, and this is the main pitfall, the difference between young and elderly patients, is really the location of the urethra. So as a woman gets older, sometimes due to lack of estrogen down in the pelvis or the vaginal area, the urethra actually retracts backwards. In a lot of cases, we'll get calls saying, well, I can't find the urethra. And I say, well, just look where it should be, but the urethra is actually retracted completely backwards. So if it's retracted back, really the best way to do that is use your finger as a guide and guide the catheter up to the midline right above the vaginal orifice, and the catheter usually slides in really without too much difficulty. But that's one of the main pitfalls we run into when catheterizing a female, elderly versus young. But no matter what you do, it's really important to understand the gross anatomy of what you're doing, where the tubes you're putting in, and where they're going. And if you understand the anatomy, you can really understand the pitfalls. And no matter what, if you do get into trouble, whether it's resistance, whether it's blood, whether it's difficulty inserting the catheter, you always know when to call for help, and that may be the most important thing.
Dr. Langani, I have a question. You being a urologist, and it's obviously we're working within the COVID environment right now. You've explained a lot of pitfalls of when you're commonly brought in to help because people are having issues with trauma to it, or maybe they're an elderly patient. But are you seeing yourself being called in more often just because maybe the medical staff just isn't as equipped and trained because there's a shortage, or what are you seeing with COVID?
I mean, we've seen that a lot. In the COVID setting, there is definitely a shortage of what I guess we'll call mid-level staff, which would be the nursing, PAs, NPs, for various reasons. COVID has really overstretched our health system across the country, and because of that, people are put in positions where they otherwise may not normally function. And yet, because of that, if there literally isn't coverage or help or the ability to catheterize a patient because of a certain nursing individual or mid-level or even a physician for that matter is not comfortable putting a catheter in, we definitely get called. So we have felt that stress as related to COVID.
So if I could just make a little joke and observation as a sales rep, I mean, I would think that this would be in high demand right now. Any type of training, or I'm kind of throwing that out there to those that are running sim centers and doing the medical education, on site, that maybe you need to think a little bit further of, some more basic stuff that maybe you just don't think your staff really needs it. Maybe they do because of this shortage.
Yeah, having a general education about these basic things from starting an IV to drawing blood to urinary catheterization. These things are all technically invasive, and they all have complications with them. I mean, even drawing blood or starting IVs can have complications. But again, you can reduce those complications when you have not necessarily patients that you practice on, but these models that you can practice on. So it's extremely important. And being in the robotic setting, we do a lot of simulation on the robot itself for prostate cancer operations, kidney cancer operations. So that's one aspect. And there's no doubt that the future of residency training is going to be some level of simulation, because I was lucky in some aspect that I was on the cusp of really learning all my education, surgery training on patients. But as things move forward, more and more residents will be like, Navy pilots, where they have to spend X number of hours in a simulator or X number of hours catheterizing on a model before they're allowed to even touch or evaluate a patient. So that is definitely where the future of medicine is going. There's no doubt about that. But models like these definitely help make people more aware. So the first time you catheterize is not necessarily on a sick elderly patient in the ICU, but you practice several times on a model and you really understand what's involved and the pitfalls based on both anatomy and technique. And then the only other thing that I did not point out, which I do, is this model also comes with a suprapubic tube element, which is important. We cover the a hospital here in Atlanta that takes care of a large population of patients with spinal cord injury, neurogenic bladder. You can see here's the same attachment to the bladder here. And again, the suprapubic tube is actually a quicker or straighter shot directly into the bladder. So this comes off. But also, I haven't seen a model such where you have access to both urethral catheterization, either male or female, as well as suprapubic tube catheterization. So that's important. And again, it's more about awareness and understanding that, yes, a tube can come from the suprapubic area and directly drain the bladder. So understanding how to change it out, how to push it in. Even more importantly, in a male and female model, you have to push the catheter until it's hubbed typically, but in a suprapubic model, that's not the case. So again, good education.
Great. All right. Well, thank you so much. Give us a moment while I switch back to our screen. And if anyone has any questions, why don't you go ahead and throw those into the chat box while I switch over. Okay. All right. Well, thank you very much. So I've got just a few questions that seem to have come through. Dr. Langani, how close does the urethra constrictor come to the real thing, in your opinion?
It actually comes pretty close. And again, the most important thing is that there's a fine line between understanding resistance and expecting it versus understanding resistance and just kind of pushing through it. So the urethral constrictor aspect of the male model is good because, again, it creates an awareness of what you may see, what you may expect when catheterizing a complex male patient. But absolutely, you'll feel that same level of resistance in a complex male patient. But again, it's important to understand that don't try to jam it in or push it through, but understand, okay, I feel resistance. I'm not quite sure. Let me pull back and call the urologist or call, an assistant who may have some more experience with this. But yes, it does represent something very close to what we do experience, when taking care of patients.
Okay, great. Thank you. Another question that we have, this is probably directed more to me. It's how do you clean the unit between sessions? So I take this unit to trade shows pretty often. I kind of hate to admit it, I'm not always the best at taking good care of it. I honestly assume my STEM Center folks are probably better at that than I am, but I haven't had any issue with mold growth or anything like that. That's a common question that I get with this and some of our other simulators, like our IV arm as well. You really just flush it with clean distilled water. You want to get a good flushing there. As far as the outside of it goes, just some light soap and water. And then often if you get, I know sometimes these get scuff marks on it or pen or pencil marks, things like that, aren't really a big deal. But if you want your unit to stay looking nice and clean for a while, I often just recommend using like one of those Mr. Clean magic erasers, just to kind of scrub the outside and get those scuff marks off. So real quick, let's see. So Dr. Langani, this one would be directed more to you. Okay. What's the most common complication of urinary bladder catheterization?
So the most common complication is trauma and creation of a false passage. And that's most often seen in the male patient. Like I outlined earlier, really at that membranous urethra where you create what's called a false passage, the tissue in that area is extremely vascular. And usually when staff is not able to get a catheter in place, we do run into a significant amount of blood per urethra. It looks typically worse than it really is, but the first call should go to the urologist to come by and take a look. And the treatment for that, strangely enough, is putting a catheter back in and leaving that catheter in place, usually for about 7 to 10 days, to allow the urethral area or that traumatic area to heal. And it heals well over the catheter. But that's usually the most common thing that we typically see with complex catheterization.
Okay, I've got another question. You might want to take a look at it. Says, where can we say at between these two links if catheterization insertion is normal catheterization?
Are you talking about the constrictor device lengths?
And then it says, nowadays, some catheter mannequins are offering catheter depth monitoring. Hold on, this is a long question.
So the two lengths, I guess I'm assuming you're referring to the constrictor band, because I said there were three levels of constriction. Typically, either the first or second one is what you want to use when training. Obviously, the third one you can use as well, with the understanding that if the trainer knows the setting, they'll know that their student or the person training on it will not be able to get a catheter past that constriction device. But on average, we do want the individual who's practicing to know what it feels like to have a catheter going smoothly, which is the open one, and then what it feels like when a catheter has a little bit of resistance, but it can still get into the bladder, which is usually the second one. In terms of catheter length, I mean, rule of thumb when we catheterize a patient, particularly a male patient, is because the male urinary tract is long, we recommend hubbing the catheter and waiting for urine feedback or urine return. So once you put the catheter in place, before you even blow up the balloon, and again, this straight catheter does not have a balloon tip on the end. This is without a balloon port. But for example, this 16 French catheter, this appendage is the balloon port. And before you blow up that balloon, which keeps the catheter in the bladder, you want to hub the catheter, push down on the bladder in centrifugation, make sure you get good urinary return. But I don't necessarily know if catheter length, as much as a guide of urinary return, indicates that you're in the bladder.
Okay, just for your reference, we just pulled us back on screen real quick.
Okay.
That way we can kind of show the different things on the catheter. So we did have a screen that just said submit your Q&A. So I just wanted you to be aware we're filming again.
Again, I'll just review that quickly for those that didn't see that. So what I was referring to is that in the male or the male model here, what you can see is that the urethra is significantly longer as compared to the female. So in that case, the rule of thumb that we use is typically hub the catheter, push on the suprapubic region, which would be, I guess, up here or over here rather, wait for a urinary return, and then understand that once you've got urine back, it means you're in the bladder and it's safe to inflate the balloon. If you inflate the balloon prematurely without urinary return, what you're potentially doing is inflating the balloon either in the prostatic urethra or again in that false passage, and that can create a lot of trauma, a lot of bleeding. So As far as how far do you insert, what's the appropriate catheter length, really it's a matter of, in the male, we advocate hubbing it to get urine fluid back. In the female, again, it's a pretty straightforward shot. So there's some element of judgment, but at the same token, you press it in, you typically do not need to hub in the female patient at all. But again, it's all about urinary return, pushing on the suprapubic region until you get fluid back. And that's an important aspect. Again, trauma can occur in the female urethra, even though it is short. So it's important not to inflate the balloon until you're 100% sure you're in the bladder.
Okay. I've got a great question from somebody who's obviously in the home health setting, which I'm sure you guys are seeing a big influx of patients with the COVID environment. They would like to know, are silicone catheters better to use in patients with frequent and chronic infections?
Yeah, so typically in the home health setting, when patients are doing what's called intermittent catheterization, this is something common in patients who are on chronic, who have chronic urinary retention, meaning they're not able to urinate at all, patients who have a neurogenic bladder, they're unable to urinate for that reason. But it avoids keeping a long-term chronic indwelling Foley catheter, which over the course of time can lead to infections, and it can lead to urethral erosion, which means literally the pressure associated with the catheter sitting in the urethra can lead to erosion of that urethral wall. And almost, I've seen openings as far back as near the scrotum because of the fact that the urethra eroded so far back in patients where the catheter was just left in place for months at a time. So in general, yes. For intermittent catheterization, we recommend single-use silicone catheters. A lot of those single-use silicone catheters nowadays come with a bacterial coating. So literally you catheterize, and once you're done, you toss it. Historically, 10, 15 years ago, they used to use a red rubber catheter, which patient would just literally wash, put it in a baggie, and then use again when they needed it. We don't do that anymore. We recommend single-use catheters that are, again, antibiotic coated. You insert it, you drain the bladder, and the next place the catheter goes is in the trash. It does not have a balloon port to it, and they come in several different sizes, anywhere range from 12 French all the way up to usually 18 French. And we usually recommend catheterization about every 4 to 6 hours, but it's all patient dependent. But yes, silicone antibiotic coated catheters will typically help reduce infection rates. Patients do not need to be on chronic antibiotic therapy just because they have a catheter in or because they're getting catheterized. So that's also important to understand, because what we don't want to do is create antibiotic resistance in those patients.
Great. Thank you. So I don't see any other questions coming in. Feel free, everyone, if you want to drop one last one in there, but thank you so much for that. I know I definitely learned a lot, and I really appreciate your time on that. I'm sure our audience did as well. Since we have just a few minutes left, I just want to mention again, 3B Scientific, we really just offer so many different types of products. So this is the Pro version, as I said at the beginning. It also comes in a basic version like this as well. And then, as I mentioned at the beginning of the session, we also have a full body mannequin that does everything. So I mentioned before, we offer a lot of products. I am not kidding when I say that. So reach out to us if you have any specific needs. I always tell people, give us your wish list of everything you really want to accomplish in your training, and we can help you find the right products that fit, that training need and your budget. So real quick, I'm just going to switch back over and share my screen one last time, just so that you have all of our information. Again, my name is Stephanie Jackson. I'm with 3B Scientific. I am the Southeast Medical Education Sales Rep, but we have sales reps across the country that are willing to help you. Please reach out to us if you have any questions regarding this. If you come up with a question after this session that you thought, oh, I really wish I had asked Dr. Lungani that, send those our way as well. We'll be happy to reply to those. And just thank you for all that you do as medical educators, as anyone in the medical industry. We really appreciate all that you do. We love working with you guys, and reach out to us. Thank you so much.